Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We appreciate your involvement with us. You remember, this is your show. You ask questions. We try to get you the information and sometimes the answers. Today we're going to be talking about orthopedic innovations with two doctors that are affiliated with HCA Florida University Hospital, which is within my eyesight from this studio. So let me introduce to you first Dr. Clive Woods, MD, orthopedic surgeon specializing in foot and ankle conditions. Welcome, Dr. Woods.
Thank you. Thanks for having me.
And then we got Roby Abraham, MD. He's an orthopedic surgeon specializing in hip and knee reconstruction. And boy, do we have a lot of folks that have been asking questions about that. So welcome, Dr. Abraham.
Thank you for having me.
We'll start with you, Dr. Woods, first. You specialize in foot and ankle conditions. We had a lot of folks that talked to us about foot and ankle, and so let's start there. One of the people said, well, maybe I'm wearing the wrong shoes, or maybe I'm doing too much walking, or maybe I'm getting out of the car the wrong way, or whatever. So let's talk about foot and ankle issues. Dr. Woods?
Yeah, so some of the foot and ankle issues that I treat are sort of what you're talking about, plantar fasciitis, or let's say someone has flat feet, which causes pain, or even down to ankle arthritis or trauma. A lot of times when they're talking about their shoe wear, as far as what are the correct shoe wear. So let's say the person that walks on a daily basis and they're, they have a flat feet. There are actually certain shoes that I would recommend for that patient to wear to kind of help with the pain that they're having. Because when people have flat feet, what ends up happening, they put a lot of stress on their tendon, and there are particular shoes that you can recommend that can help with that, which even myself, if I go running 2-3 miles and just any pair of sneakers, my feet hurt. However, if I put on a pair of shoes, what they call for pronation, that usually helps me out a lot.
Do you, in your work, no, obviously as an orthopedic surgeon, but you must do an awful lot of, I guess, advocating and advice to your patients that do not require surgical intervention. Is that true?
Yes. So some of the things that I kind of discuss with them, one is appropriate shoe wear. So, people that wear high heels with, narrow toe boxes, of course, that can cause pain. In addition to that, I also discuss, let's say they have plantar fasciitis, getting shoes with more of a cushion. We already discussed about, if they have a flat foot deformity, meaning their foot is flat. In addition, another little trick that they can do sometimes is that a lot of patients have heart conditions, high blood pressure. So the best time to actually look for a pair of shoes is not in the morning. It'll be sometime in the afternoon or evening that you've been standing and your foot's a little bit more swollen, because if you get it in the morning, it may feel right, but by the end of the day, when you have the swelling from whatever conditions you have, it may feel more painful and more tight in that shoe wear.
There were a number of questions. As I say, this show really is driven by questions from our viewers. We've been doing this for over 22 years, so I listen to what they want to hear about, and I'm here to try to bring people forward, experts like yourselves, to try to help them out. There's a lot of folks that are living in that category of past 65, 70, 80, up to 90, 100, that have a lot of problems inherent with diabetes and issues like that. How do you deal with that?
So usually from the diabetic standpoint, a couple things. One is they got to definitely check their feet. So it's not advisable for a diabetic patient to walk around barefoot. Because if they have any sense of neuropathy, meaning that the sensation in their feet are decreased, let's say they step on a pebble, that can lead to ulcers and wounds. which a lot of times for myself, I usually would send that to like a podiatrist who usually does the foot care for me. In addition, podiatry would talk about like nail clipping. So let's say if they have, their toenails along, sometimes when they clip their toenails, they may clip it too short, cut their toe, and end up with an infection. So a lot of times podiatry would handle that. Where I come into play for diabetics are if, let's say, a diabetic gets a condition called Charcot-arthropathy. And what that is that going back to that lack of sensation, sometimes they can get micro fractures, so meaning little small hairline fracture that they may not feel and they continue to walk. And then what ends up happening, you get destruction of the joint. So a lot of times I would have to either one, cast them, two, from a surgical intervention, we call fuse the foot. So whatever joint is destroyed, stick those two bones together so they don't move, and get their foot more aligned. In addition to that, help with whatever pain they may be having from that.
Okay, well, thank you. Dr. Abraham, your area, we have so many questions that have come in. Again, I repeat that we have so many folks that are beyond the age of 70 and up. And then, of course, we have a multiplicity of issues relative to bone fragility. I won't get into the issues of estrogen and progesterone loss and things of that nature, but you do see the multiple people who have hip fractures, and I would assume the knee issues either would they be replaced or worked on to repair. So let's touch about that broad subject, because we have so many questions that come to us about hip and knees.
Yeah, sure. So, knee pain and hip pain are very prevalent in our community. It's probably somewhere in the top five, or probably even top three diagnoses for urgent cares, especially, and sometimes some emergency room visits. A lot of times for hip and knee pain, it's because of arthritis, especially when you're talking about an elderly population. But the key for this is to understand that there are some things that we need to look for in knee and hip pain that are very severe or dangerous, And one of those things I always say in all these talks is, if you find that your knee is not just swollen, but red, hot, and, inflamed, it may not just be regular arthritis. You may have an infection. So that's kind of the first thing that everyone's got to kind of make sure they seek care immediately, whether it's their primary care, who then refer them to an orthopedic surgeon like myself, or if it's very severe, going to the emergency room. And that's about less than 5% of the hip pain or knee pain that comes emergently. But again, one of the more important things not to miss. Now, the rest or the brunt of hip pain, knee pain usually happens because of osteoarthritis. And basically what that means is that you have a loss of the cartilage in your knee or your hip. Now, cartilage lines the bones. There's cartilage on both sides of the bone on a joint, right? So the joint is made by two bones that kind of join or meet each other. So when you lose that cartilage is when you start having both bones rubbing on each other, grinding on each other. So a lot of people may come and have that sensation of cracking and grinding. These are all kind of very common complaints that people have. The first mode is one, obviously, to come in. We get your history and physical. A lot of people have it for different reasons. Some people, it may just be wear and tear of your body, where throughout the years, your cartilage wears down, your meniscus, which is another thing in between the bones. It's the shock absorber in the knee, that wears down. Same thing on the hip side of things, your labrum, that can wear down. And these are all very kind of technical points, but all these things are soft tissue that over the years wear down. The other thing would be if, some people on the younger side of things may have injuries when they were high school athletes, when they were college athletes, or maybe even grad school or recreational sports, and they have injuries in their 20s and 30s. And, when you're at that age, you can kind of rest for about a week or two, take some anti-inflammatories, and it'll go away. But it doesn't necessarily mean that the injury itself is completely healed. And that may have repercussions for later when you're in your 40s, 50s, or even 60s. So that early arthritis. I tend to treat people who are anywhere from 40, 50 to almost 90, 95 years old. So that's a big spectrum. And, people come for different reasons. Now, I'm going to just touch on one more thing that you had mentioned about hip fractures and bone density. So that is very important, and something that everybody in terms of the primary care aspect should check. Everybody should get their bone density exam every year. Of course, speak with your primary care physician about it, but that's just to measure how the density, how your bone strength, essentially. So a lot of people have something called osteoporosis. And when you have weak bones like that, something that, you may be in a shopping plaza and trip over the curb and may have a soft little landing or something like that, that might cause a hip fracture or a spine fracture or even a wrist fracture. That's something that, me or Dr. Woods or anyone else wouldn't probably get if we did do that. So that's always something that's, it is a treatable thing, osteoporosis. So it's something definitely to ask your primary care physician about, because they usually will check yearly anyway to make sure you don't have osteoporosis. And there's great medication for that to at least alleviate that problem. But, that's kind of a little bit of a different spectrum from the regular bread and butter kind of hip arthritis and knee arthritis that we see, but just as important.
Your point about bone density testing, I think, is an imperative, particularly, and you tell me if I'm wrong, in females, because there is a loss of the estrogen progesterone balance.
Mm-hmm. Yeah, estrogen is really important for, just to get to kind of specifics, a certain cell in the body that breaks down bone. Estrogen actually prevents that from acting. Now, when you lose the estrogen, it's like that, that there is no check on that cell, and it starts to degrade the bone, essentially causing less dense bone because of that. So estrogen is essentially the check for that. So when women go through menopause and lose that checks and balances for the bone, it starts to slowly lose its density. So it's really important. I mean, and I usually, both of us do a lot of hip fractures here in the hospital. And one thing we always say is it's a sentinel event. When you get one, it opens the door to all the other injuries that are possible too. So, we always say, go to your primary care doctor, who will get the bone density test. Inevitably, they'll probably, if there's issues, they'll send you to an endocrinologist who will help with the hormonal balances for the bone, essentially putting you on things like bisphosphonates, and depending on, each individual patient, the dosage, the type of medication, all that. But these are important things that at least, a platform like this brings awareness to that thing. Because, just getting one hip fracture, and luckily, if everything is okay and all, the surgery is done and you go back to activity, it doesn't preclude you from having other fractures in the spine, or even, God forbid, your other hip or your wrist or any of these things.
Let me get to another thing relative to the knee issues. Again, Dr. Woods, I don't mean to. We'll get you back into it. We're still on the upper part of the body, the leg. I mean, there's of course we do know. Obviously, you got the weekend warriors. The people go out and play tennis and do whatever they're doing and do the running but there's so much going on. We have a question from a nurse professional that just retired. So I guess this particular person probably was standing on her feet, a good portion of the day, probably more than a half a day for 30 years, and had surgical intervention to do meniscus repair. That must be a very common thing. Is that true, Dr. Abraham?
It is. So, I'd like to think of the meniscus almost like a tire in a car, right? So around 30, 40,000 miles in a car, you start seeing the threads come, right? You start seeing the thinning of the tire. You start seeing the shredding or the threading of the tire. And at that point, there's a little bit of a philosophy change. At that point, when you go to the auto shop, they're not going to say, well, let's just shave the threads and the kind of shredding of the tire, and then you drive on off with the rest of the tire, because inevitably the car will plop on that side, right? So usually what they recommend is you need to change out the tire. So in our kind of analogy here, going back to the knee, the meniscus essentially shreds in the same way when you have meniscal injuries. And as you get older, the composition of the meniscus is almost kind of like the bone. As the bone gets less dense, the meniscus itself gets less able to handle the pressures of the knee, right? So it's not as elastic or plastic. So something where you may even be, for your example with that nurse professional, she may be walking down the hall. She forgot her her folder back in the desk. She makes a quick turn back the other way, and that meniscus is going to start. It may not be able to handle something like that, even something that simple, and you may have a small little tear there, and that's when you feel that ow. And after that meniscal injury, something that small, you start getting swelling in your knee. It starts, ballooning up. And once that happens, you need to get rid of the inflammation. Now, my treatments for, meniscal injuries and meniscal tears, especially, and this is, really dealing with people who are like 40 plus, 50 plus, who have these meniscal injuries, because these meniscal injuries are essentially degenerative meniscal tears. Essentially, the meniscus was breaking down anyway, and because of that, a slight little turn or twist or maybe too much walking caused the meniscus to tear. It's really different from something where maybe a college athlete, they're running on a football field, they're playing a game, they make a quick twist, and they may be hit in the leg, while they're trying to make a play. And that's very different, that type of injury, where if you have a meniscal tear there, that's something where you have one clear line, essentially most of the time, that you have a tear. And then someone that young, 20 years old, depending on where the tear is, you can actually repair that. But when you get to the category of degenerative meniscal tears, something where it's above 40, 50, it's really hard to repair something like that. So when we talk about arthroscopic surgery, camera surgery in the knee, when we go in there, it's all shredded up it almost looks like a tire that's really shredded up. The problem is when we get in there, we'll try to clean it up, but essentially we're taking away some of the meniscus too, which ends up being the problem. So a lot of times for meniscal injuries, at least, and meniscal tears, when people come to me with a swollen knee and you have that, first we try, anti-inflammatory medication. This is your Advil, Aleve, Motrin, more higher prescription things that we give. All these anti-inflammatories to get the swelling down. Icing it also helps, and resting it helps. Doing that for a few weeks, either 2 to 4 weeks, sometimes 4 to 6 weeks, is imperative. The other thing that I say is after that initial 2-week period, maybe we can start doing some physical therapy. And that's really to get your flexion back, your extension back, starting to move your knee and strengthening your muscles. When your meniscus fails, your cartilage fails, what's really important is the things that you have control over. You cannot grow your cartilage back, at least right now for where we stand, and you cannot grow your meniscus back, right? There's no supplement that we have. There's nothing really at play right now. But you could strengthen your muscles, your quadricep muscles in the front, your hamstring muscles in the back. Those are things that you have control over and patients have control over. So physical therapy is a crucial portion for healing from a meniscal injury. And that's essentially the brunt of that treatment. We're doing that for at least 4 to 6 weeks, with that treatment. Now, sometimes it still doesn't get better. because and the swelling is still in the knee, we can deliver that medication locally to the knee with an injection. So there's steroid injections that we can do, and the steroid is another medication that functions kind of like an NSAID, an anti-inflammatory, and what it does is it locally delivers the medication to the knee. And this will get the swelling down and should be something that's very effective. Usually I push patients to do that often and as much as possible before going to surgery.
Dr. Woods, I'm going to get back to you for a second because you mentioned your relationship to podiatrists. Do you have any advice to the people about visiting a podiatrist on an annual basis or 4 times a year, 3 times a year, whatever? What's your information?
Yeah, so what I would say about that is it depends on the condition. So one, if it's, let's say, someone that's really neuropathic, meaning they have no sensation or their sensation is severely decreased, I would definitely tell them to visit the podiatrist often for like toenail clipping. Now, if they have, let's say, the patient has like a diabetic ulcer because they weren't checking their feet and now they have like a wound there, that is definitely, you're going to have a lot more visits with that podiatrist so that they can, make sure that wound heals correctly and that it doesn't get infected. So a lot of times it depends on the condition. If it's just a prophylactic purposes, usually once a year or once every 6 months is sufficient.
With reference to, you made the point about the high heels issue. I know I don't like to get into the male-female issue, but the high heels, sometimes they're 6, 7 inches tall. I mean, isn't that a dangerous thing for the structure of the foot itself?
Oh, for sure. So one is just the makeup of the shoe. So from the standpoint of these high heels, you're putting a lot of times when you get to the forefoot, meaning the front of the foot, that's narrow. So what ends up happening is it can create things like bunion deformities, meaning that the big toe starts to shift in and they get a prominence on the inside of their foot. So that's a common condition that I see and I treat, and depending on their pain or let's say I say, hey, let's try wider shoes, let's try padding, let's try ice. If that works, we continue with that treatment. However, if they are like, it's still bothering me, then we correct that deformity through surgery, whether it's minimally invasive with small incisions, or depending on, if it's more severe, then we have to do an open procedure to correct that alignment. In addition to that, with high heels, what ends up happening is now you're putting a lot of pressure on the front of your foot, so the forefoot. So now you're taking the pressure off your heel and you're putting on the front. So a lot of times people can get stress fractures in the front of the foot, things we call bursitis, meaning inflammation on the balls of the feet. That's another common condition. And then the biggest one that I've seen too is that when women wear high heels, let's say you're walking and you step in the crack of a paver or you miss a step, you get a lot of ankle sprain, ankle fractures, which, a sprain a lot of times can be treated with therapy, bracing, and anti-inflammatories. But sometimes these fractures I have to take back and fix just to get them to walk so they don't get arthritis in that ankle.
Well, thank you. Again, this is it's another question that came from a viewer. I thank you both for. Tell me, Dr. Woods, Dr. Abraham, where do you practice out of? Which are you in the entire system, or you out of particular hospitals?
So, from the standpoint of myself, as far as the hospitals, I'm in all the hospitals in Broward. So that's University, Davie, which is on your campus, West Side, which is on Broward Boulevard. Also, we have Woodmont Hospital, which is on University and like McNabb. And then I also go as far as Margate for Northwest Hospital. As far as my office, I see patients in the Plantation office, which is about 10 minutes from University Davie. And then I also see patients in Margate, which is on the north end of the market. So I can provide care both to the south and north end.
And Dr. Abraham?
Yep. So pretty much the same thing. I'm in all four of the hospitals. I have the same clinic over in Margate, which is convenient. It's right across the street from Northwest. All these offices that we have are right across, or either part of the campus or right across the street from the hospitals. And the plantation one I have as well. We also have a small satellite clinic over in Woodmont Clinic, also in the campus of Woodmont Hospital, just to service that Tamarack area, which is a big place for retirement communities. So we're also there just to make sure they don't have to travel too far out of town.
Okay, well, I thank you both for being here today. I just thought, it was interesting because we got so many comments, particularly about hip fracture and, believe it or not, toenails. So, there's so much more to talk about. But I want to thank you for not only your capabilities as professionals, but also for your willingness to share the information. We thank you very, very much. This show is really, like I say, I always tell the viewers, and we've been doing this now, like I said, for 22 years, so we listen to them. It's very easy for me to just ask the questions. But I've always told them that if they have a problem, if they have pain in their ankle, they have pain in their foot, they have a knee problem, whatever, don't hide it. Don't try to self-medicate. Just because you have the opportunity to purchase things in pharmacies or supermarkets or wherever, make your doctor aware of it. Your primary care physician is very knowledgeable with reference to their responsibilities, to their relationship with persons like Dr. Woods and Dr. Abraham. So what you need to do is make your primary care physicians know what's going on, whether it's a primary care, internal medicine, OBGYN, whatever. Let them know, because it's only for your benefit. So thank you one more time, Dr. Woods, Dr. Abraham. We hope to see you more often. If you're ever around the campus, just come on by and say hi. Yeah, maybe I'll even give you the opportunity to buy me lunch. But that's beside the point. Folks, this program is called Dateline Health. There's a telephone number and an email address right here. If you have any questions, just get them on to us. And remember, as I always tell you, take good care of yourself. My name is Fred Lippman. This show is called Dateline Health. We come to you from Nova Southeastern University. See ya.
Specific, because it's right over that fracture. They'll have specific, because it's right over that fracture. They'll have